Good afternoon. It's nice to be here. This is always a really fun class to work with, and I encourage your questions. I'm going to try to follow the format and get through the presentation, but take questions at the end. But please do hang on to them, because I know this is an industry and a topic that stimulates a lot of really good discussion, and there are some very diametrically opposed ideas about what should healthcare cover and what shouldn't it, and certainly in the last year with the Patient Protection and Affordable Care Act, there's been an incredible amount of media coverage of the new health reform bill, and a lot of very strong opinions on both sides of the political spectrum. So I wanted to start with responding to the report on the health and care industry study that the four of you have put together, which I thought was really wonderful. And I guess maybe I should start with a disclaimer, which is that my work is representing providers, hospitals primarily, some large medical practice groups. I do not work with the health insurance industry. And very often you will see that the health insurers blame the health providers for the high costs in health care, and the health providers blame the health insurers for the high costs in health care. And I think the answer probably lies somewhere in the middle. But I thought the focus of the paper and presentation was very good, because it looks at the insurance market and how that is affecting the healthcare industry. So in my presentation, I'll give you a little bit of a different perspective on the provider issues associated with rising healthcare costs. But it is an interesting ability to compare and contrast. Your report focuses on deficiencies in the U.S. system, where in 2007, 42% of the adult non-elderly population, and for those of you who think anyone over 50 is elderly, by non-elderly we mean under 65, are either underinsured or uninsured. These people tend to be, 80% of them, working individuals. They are not unemployed individuals. And they essentially tend to forego needed medical care because they can't afford to pay for it. As a result, they end up in emergency rooms where hospital providers are required to treat them regardless of their ability to pay, and therefore become a very large portion of what we call uncompensated care in the health provider sector. Now, the Patient Protection Affordable Care Act, which is known by PPACA, so I'm going to use the acronym because it's much quicker, intends to address some of this by requiring coverage by individuals and making available affordable choices to those individuals, along with individual tax credits, for those working uninsured to be able to afford at least a basic policy of health insurance that covers catastrophic illness and preventive medical care. And I'll go into a few of the details of the major provisions of PPACA, and you can come to your own conclusions about whether it's a good thing or a bad thing in terms of the deficiencies in the U.S. system that have been identified in the report. In looking at the insurer versus provider side of this and the difficulty of the healthcare industry, I would note that your report shows a 10% profit on average in the health insurance industry, some of which you've pointed out is really fueled more by non-health sides of the insurance business, but nevertheless these companies are making 10% double-digit profits. You would be hard-pressed to find a provider of the size of a hospital making anywhere near that level of profit. Now, many of them are not-for-profits, but nevertheless their rates are controlled by Medicare. And so if hospitals look like they're making too much, they start getting lower reimbursements. So the profits are not really in the provider community. And if you talk to many physicians in private practice, so many of them are leaving private practice and joining very, very large hospital-owned physician practices of 450 physicians, primary care specialists, because they cannot make a living providing medical care anymore. It's both not remunerative, their fees are continuing to be cut back, and the costs and time associated with that kind of work are just way more than a small business, which is what most small medical practices are, can afford to provide. About the use of electronic medical records as a means of reducing costs. And in fact, it very much is not only a means of reducing costs, it can lead to huge improvements in quality of care provided. When physicians and specialists can share medical records by just sending them electronically, they have access immediately to allergies of patients, and they don't have to continually repeat all these questions and have you fill out the same form 20 times when you go from your primary care physician to a specialist for care. The potential improvements in quality of care are just really, really significant. And electronic medical records are something that the government has been trying to promote and provide incentives to particularly physician practices, because many hospitals have implemented an electronic medical record. They have seen the benefits and the efficiencies of having an electronic medical record. Fewer claims processors, electronic submission of claims, standardization of forms and bills. And in fact, the estimates of $51 billion in savings are not in fact, kind of out of the realm of what's really reasonable. When HIPAA, which everybody knows is a Patient Privacy Act, was put in place, it mandated that there be standardization of claim forms, standardization of what every Lehigh Valley Hospital had one designated identifier. Every provider had one designated identifier. Each patient would have one medical record number or one identifier. These sound like simple things, but when you're dealing with a patient who is seen at 4 hospitals and bills have to go to 4 hospitals using 4 hospital forms and designation of the patient by 4 different numbers, it leads to a tremendous need for lots and lots of claims processing people. So when HIPAA was put in place in 1996, among the requirements was that not only were these forms to be standardized, they were to be sent electronically, just claims forms. And at that time, they estimated the savings would be $86 billion over 10 years. Now, I'm not sure they've achieved that. But nevertheless, that clearly huge and significant savings. The problem, however, and I don't think you addressed this in your report, is that the upfront costs of putting in place an electronic medical record system for physician practice is astronomical. And our government tends not to mandate so many things, but to provide incentives to do these things. And so there have been a number of incentives to physician practices to do this. For one, when I talk a little bit about government regulation, hospitals are not permitted to provide free goods or services to physicians that send patients to the hospital, except that there is this very narrow band of exceptions. An exception was created to allow hospitals to fund 80% of the costs of providing an electronic medical record in a physician's practice. So that was the first incentive that was put in place maybe 4 or 5 years ago. The Federal Recovery Act has provided additional subsidies to physicians who do put in place electronic medical records that increase the earlier they put in place their electronic medical records, so they can get more dollars over a limited period of time if they put this in place. Likewise, some of the provisions in PPACA provide lower reimbursement if they fail to do this by, I believe it's now 2018. And so that's typically how the government deals with healthcare. They try to provide the incentives rather than just mandate everybody has to put an electronic medical record in place, because that would bankrupt a number of small physician practices. And so while that is in fact where we need to be, the costs of financing that are really going to be a critical issue. Lastly, I would just note that in talking about PPACA, and again, in the interest of having both sides of the debate, out there, so you can all make up your minds about what is or isn't appropriate. You do note that Florida and Virginia have ruled, district courts in those 2 states have ruled PPACA to be unconstitutional. district courts in West Virginia and Michigan have ruled PPACA to be constitutional. And so this is a question that the Supreme Court will ultimately get and decide. But at least last count, we've got 2 courts saying yes, 2 courts saying no, and we'll go from there. We'll see what happens. I wanted to kind of give you the provider perspective on this industry, and I'm going to zoom through some of this because my statistics are remarkably identical to yours, and even though we had different sources, it's always reassuring to see that in fact the statistics about the industry and the number of uninsured and the costs of health insurance are in fact consistent depending upon who you're using for your source. But what I did want to do is just kind of as an overview go describe for you today a little bit about what the healthcare industry is, some key industry statistics, how healthcare is currently financed in the US versus how it's covered in other countries. Talk a little bit about PPACA and the major provisions, the role of government in the healthcare industry, regulation of the healthcare industry, and what I see are some of the most critical of the major issues facing the future of the healthcare industry. Very similar to the approach that you all took, and in fact you'll see lots of these ideas repeated. What is the healthcare industry? Well, it includes providers, patients, payers, product providers. It's a very diverse group of different industry sectors or sub-industry sectors. These statistics are ones that you've heard in the report that was provided. 2009 total U.S. healthcare expenditure, $7,900 per person, about 4 times gross domestic, 17.6% of gross domestic product and 4 times the amount spent on our national defense. And rising at more than twice the rate of inflation. And that statistic is actually somewhat old, and I think in the last 2 years, it's even more than that, given that inflation has been so low.
The chart they have is amazing.
Yeah.
The price increases.
Yeah, and it just keeps going. Health insurance premiums, I think the group really adequately covered that. The annual premium for an employer-sponsored health plan covering a family of 4 is $13,000. So you have to add $13,000 to what an employer pays their worker in order to provide health insurance. Health insurance premiums in the last 10 years have risen by almost 120%. The number of people covered by employer health insurance has decreased from 70% in '87 to 62 in 2007 to 57 in the last 2 years, in 2010. So you can see as the costs have increased, the number of employers, and particularly small employers, who can afford to provide health insurance to their employees has decreased. And as a result, we have this burgeoning population of uninsured and underinsured American citizens. 46 million. 7 million alone have lost coverage in this last 2-year period because of the economic downturn. 1 in 5 have no health insurance. 80% of these are in working families. The number of uninsured children is 8 million, or roughly 10% of children. So we've got this huge growing population of uninsured in this country, which leads to a tremendous increase in rising costs. And you'll see why a little later, because at least not-for-profit hospital providers are required to provide care, even to the uninsured, even to those who have no intention or ability to pay, regardless of their ability to pay. So how do we finance healthcare in the U.S.? We have a variety of governmental programs: Medicare for those over 65, Medicaid for poor and disabled, and the SHIP program, which is specifically covers children. And then we also have employer-sponsored health insurance and individual health insurance that individuals procure. Other countries. The UK provides universal coverage. The cost per citizen is about $3,300 per capita compared to our $7,900. But the issues with the UK system tend to be long waiting times, inadequate funding, and an inadequate number of providers. Same thing in Canada. Canada's universal coverage is administered by the territorial authorities, but their healthcare costs are greater than 40% of those individual territorial budgets on average. same problems with long waiting times and inadequate funding. In France, they provide universal coverage through a combination of national insurance plans. The cost, and these statistics are 2007 statistics, which were the latest that I could find, are about $3,900 per capita, again, compared to our $7,900. Their healthcare spending is 9.8% of GNP as opposed to our 17.6% of gross domestic product, and they are facing huge debts in order to provide this coverage. The state health insurance plan funded from both employer and employee contributions, along with subsidies for poor, unemployed, and elderly, but they cover approximately 90% of their population. Japan has a combination of national health insurance and employee health insurance. They do provide universal coverage, but they are facing some significant problems because of the shrinking workforce and a very significant growing elderly population there. All right, let's turn to PPACA. Signed into law March 23rd, 2010, almost just a year ago. And look at some of the key provisions in this health reform proposal. Principal provision is that the law sets up 50 state exchanges administered by the states, not the federal government, in which individuals and small businesses can obtain coverage from private insurers and co-ops. No government takeover of health care. These are state exchanges that provide a forum for private insurance companies to offer plans to individuals and small businesses. In addition, because in some states you will find that there are insurers who don't want to insure the population. This is true, unfortunately, in some states like Alabama, where the coverage issues are really significant. In that instance, the Office of Personnel Management would contract with private insurers to offer at least 2 plans in every state exchange. So the government would provide at least 2 plans from among a panel of insurers that individuals and small businesses could obtain coverage from. And these plans would be similar to what's provided by the Office of Personnel Management to members of Congress, to our senators and representatives. There is no employer mandate to offer health insurance in PPACA, but there is a penalty. If the employer has more than 50 employees and does not provide health insurance, and at least one of those employees takes advantage of the premium tax credits available for individuals to procure health insurance, then the employer has to pay a fine, and that fine is equal to $2,000 per full-time worker, exempting the first 30. And this provision does not kick in until 2014. The goal here is, remember, $2,000 per worker as opposed to $13,000, which is what they would pay to provide a health insurance policy for that same worker right now. And the 2014 effective date is an effort to get these state health exchanges in place so that employers can, in fact, go to that marketplace and decide, are there basic health insurance plans that are affordable that I can provide to my employees through this new marketplace that opens up for the insurers a much larger population. And when you have a much larger population of people insured under a particular plan, you can bring your rates down because your risk is now spread out over a much larger population. One of the reasons that small businesses have had such a hard time finding affordable health care is that with a very small employee population, the risk to the insurer becomes very high. If you have one case where someone has a chronic and catastrophic illness, or you have one baby who spends a year in the neonatal intensive care unit, that employer sees health insurance premiums the next year skyrocket because they can't spread that cost and that risk over a large population of employees. So one of the goals of these state exchanges is there will be large numbers of people from multiple businesses and individuals participating, and the risk can be spread among all of those individuals. And so it's an insurance concept that works well in national plans, but these will be state-run plans.
Have the states started on this, or are they waiting until some of the
Some states are in the planning stages, but there has not been much that's actually been put in place yet. No, no. You know, 2014 sounds like it's right around the corner, but given all the uncertainty that PPACA has generated and the constitutional challenges, I think there are a lot of states taking a wait-and-see approach, unfortunately. So while there's no employer mandate, there is, in fact, an individual mandate in PPACA, and that is the requirement that U.S. citizens and legal residents have qualifying health insurance coverage or pay a penalty. Now, the penalty is $695 per person, up to a maximum of $2,085 for a family, or 2.5% of household income. Once again, the penalty will be phased in and not start until 2014 to give those individuals the opportunity to go to the state exchanges over the next couple of years and see whether they can afford health insurance coverage. Generally, based on the surveys that have been done, people want health insurance coverage. They're not saying, I don't need it, I don't want it. They just can't afford it. And particularly younger people who think, I'm not going to get sick, I really don't need this right now, they would still rather have it because it is a backup. There are numerous exemptions, by the way, to the individual mandate for income level, financial hardships, religious objections, but this is the provision of the bill that is being challenged as unconstitutional, is this individual mandate. And so we will have to see what the Supreme Court does with this once they get it. PPACA expands Medicaid eligibility to cover individuals with incomes up to 133% of the federal poverty level. That's about $29,000 for a family of four. And that provision is expected to increase the number of Medicaid recipients to about 15 million. So 15 million of currently uninsured population would be covered through the expansion of Medicaid. Overall, PPACA will reduce the number of uninsured by 42 million by 2019. We're still 10 million short, but it will have a significant impact on the numbers of uninsured in this country. How do you pay for this? Well, on an individual level, there will be individual tax credits, a sliding scale premium tax credit, cost-sharing subsidies with families, for individuals and for families who have incomes between $24,000 and $73,000 in the case of a family of four or more. There will also be subsidies to small employers who offer health insurance to their employees. And small employers in this context are those with no more than 25 employees where average wages are generally less than $50,000. Big issue for PPACA is the cost. The Congressional Budget Office anticipates that the cost will be $938 billion gross. That's a huge, huge number, even by today's standards. 814 billion net. How's this going to be funded? Well, it's going to be funded by savings in Medicare and Medicaid payments. And that translates to reductions in payments to hospitals and physicians, increases in what are called Part B and D premiums for higher income beneficiaries. Part B are physician office-based care, and Part D are the prescription drug plans. Also be funded by new revenue from an excise tax on high-cost insurance, Cadillac plans, they call them, of $32 billion. And this has been a very controversial provision. Lots of senior executives in large companies have a health benefit plan that is so rich and covers so much, where most of the rest of their workers have your basic plan. And so one of the ways this is going to be funded is to tax those extremely rich plans if they continue. They may not continue, but clearly this is going to be a disincentive. There will also be fees on drug companies, medical device makers, and insurers. One of my favorite is there's going to be a tax on tanning services. So any of you who may take advantage of tanning services will now have to pay a federal excise tax that helps fund some of these new insurance proposals. Other key provisions in the bill, health plans cannot deny coverage based on pre-existing conditions, rescind coverage in the event of an illness, or base premiums on health status. Pretty much every side of the political spectrum is in favor of this. And I know near and dear to all of your hearts, it's already been mentioned, parents can now cover their children up to the age of 26 on their health plans. Those are the key provisions, essentially, of PPACA. And again, what ends up happening to the bill, if it is upheld, it will go into effect pending all of these constitutional challenges. And so we are likely to see more and more activity as we get closer and closer to that 2014 date. When it will actually come before the Supreme Court for decision is anybody's guess. But
Can I just, because I know a lot of you were paying attention to this last year. This was such a huge deal. This was really a big deal. With the biggest change in the system and maybe ever. And I hope that's not lost on you. If you weren't really following it, the debate, but this was a really big deal.
yeah, this would dramatically change healthcare delivery in so many ways. I have not focused on many of the smaller provisions. This is a 2,000 something like that page bill that has all kinds of very special programs for preventive care services, for smoking cessation, for weight reduction, for reporting health quality statistics by all providers to a national data bank that will allow you as patients and consumers to go in and access and see what this hospital's record for cardiac arrest services and survival rates is compared to this hospital's. It will give a tremendous amount of information to the individual consumer to be able to make more informed and better decisions about where you want your health care provided and what problems physicians and hospitals have had in the past. Dramatic changes. It also provides some of the incentives for physician practices in particular to adopt electronic medical records and providing the subsidies to help them to do that. Other provisions that are going to be extremely helpful. All right, now what I'd like to do is turn very quickly to the role of government in the healthcare industry. This is one of the most regulated industries within this country. There are a lot of historic reasons for that, but many of these regulations just do not go away even when the basis for which they were put in place seem no longer to exist.
Old regulations never fade away.
Exactly. And so my job is really trying to find ways to help hospitals and physicians do what they need to do in compliance with a lot of these regulations. But first of all, the government regulates a lot of different things in healthcare. It's a major payer through Medicare, Medicaid programs. It's a major provider. There are a lot of VA hospitals and government clinics. It's the guardian of public health through licensure, quality, safety, rules, and regulations. And it is a main regulator of the healthcare industry. I'm not going to go through this, but these are the numerous government agencies involved in regulating healthcare providers. And then if there weren't enough industries, there are even more acts, federal, state, and local, that regulate virtually every aspect of the healthcare industry, from competition to quality to what physicians can and can't do, whether they can make profits. It's pretty extraordinary. But let me just quickly do an overview of these different areas of regulation. First, qualifications to provide medical services, and these usually come through state licensure, certification, accreditation, and credentialing agencies. They're the boards of physicians in the state who regulate which physicians get licenses. Other clinicians, they're the boards that regulate hospital licensure and other facilities. Second area of regulation is the quality of care delivered through on-site inspections by a lot of these governmental agencies, review, and increasingly mandatory reporting to various departments of health and accreditation agencies. And increasingly, that reporting is becoming public information. It's no longer non-public. Another area of regulation is in the provision of emergency services, primarily through something called the Emergency Medical Treatment and Active Labor Act, EMTALA. This is, in fact, the provision, among others, but this is one of the main provisions that has compelled hospitals to provide care to those who have no ability to pay. And it's driven the costs of hospital care up dramatically because those costs and expenses have to be covered by someone, and they're covered by paying patients and insured patients. Interesting kind of history to this act, which I'll tell you just as a way of describing how some of these regulations evolve. There were a number of cases in which women from Mexico who were pregnant were coming into the United States just before they were about to give birth so that their children would be born in U.S. hospitals and become U.S. residents. And instances where those border Texas hospitals were overwhelmed by the volume of these cases and were turning these women away in the middle of active labor. And there were a number of disasters that happened, and a great hue and cry, and Congress said no more. You know, in this country, if you show up in an emergency department with an emergency medical condition, you will either be treated, or if the hospital doesn't have the capability of treating you because it doesn't provide a burn service or some specialized care, your condition will be stabilized and you will be transported to another hospital for treatment. And so the EMTALA Act originated because of those couple of, well, it was not a couple, but a number of disasters, and a hue and a cry that this is not what this country stands for, and we will not tolerate this. Many other mandates to provide coverage or a certain level of coverage have arisen that way too. There was in the 80s a great uproar about what they call drive-through deliveries, where women who were going through normal vaginal deliveries were told, you can leave the hospital the same day as the birth of your child, and you don't need to stay overnight. This was in the era of managed care when hospitals were trying to control costs, and concluded that, you know, this woman and her baby did not need to remain in the hospital. Again, public uproar, and Congress steps in and says, mandatory one-night overstay, regardless of the woman's condition. And so a number of our statutes and our regulations have developed because of these kind of awful situations. Another area of regulation is patient privacy, near and dear to all of our hearts, that providers have to disclose in writing how they can use health information about us, and you as a patient have a right to a copy of your record, to amend your record, assuming the amendment is accurate and appropriate, and to obtain an accounting of how any of your providers, whether that's a physician or a hospital, have used your information or to whom they've sent your information. I described earlier one of the first efforts of the government to start trying to standardize the claim process, the billing process for claims, and to start using nationally recognized identifiers for individual hospital providers and physician providers to try to realize some of those $50 billion in savings from making this process electronic. HIPAA also required a number of physical software security measures to protect health information as well. Another area of regulation is protecting against what they call fraud and abuse in the healthcare industry, and there are three major statutes involved in this: the Physician Anti-Referral Law, often called the Stark Statute, the Anti-Kickback Statute, and the False Claims Act. Just very quickly, the Anti-Kickback Statute says that there may be no payment or receipt of any form of remuneration in exchange for the referral of patients who are covered by the Medicare and Medicaid programs. That essentially applies to the whole population of patients because, with the exception of pediatricians, most hospitals and physician practices have more than 50% of their patient population is Medicare. Essentially what this says is if a primary care physician sends a patient to you as a specialist, the specialist can't pay the primary care physician for that patient referral. They can't even buy them tickets to a baseball game or a holiday fruit basket, because that's considered a kickback. This is how arcane this law is. And the notion on which this law was developed was that you go in, you go into medicine as a calling. Profits should not be made in the healthcare industry. That's unseemly. You should be acting in the best interests of your patient, and you should never be motivated by whether or not there's a benefit or a reward for sending this patient for care. And so that was the origin of this statute, as well as the Stark statute. But in this day and age, unfortunately, they're in serious need of revision. The Stark statute is even more restrictive. And it says a physician may not refer a patient to either an entity like a hospital or for a service if that physician has any ownership interest in the entity or service or financial arrangement with them. So if the physician has a contract with the hospital to be a medical director of a certain unit and practices in the community, that physician can't refer any of his patients to the hospital for services unless one of 26 very narrow exceptions are met. And the very narrow exceptions have 18 to 20 requirements associated with them. And again, the notion being that physicians should not profit from the practice of medicine. It's a calling. So one of those exceptions happens to be the ability of hospitals to provide funding of 80% for development of electronic medical records in a physician practice. So the government is trying to keep pace with providing some incentives that are going to move the industry forward. But we're stuck with this particular statute, among others, that still is so restrictive that physicians, for example, who develop special prosthetic devices because they think it's a better thing for their patient than what's currently on the market, they have a choice. They can continue practicing medicine and not refer any of their patients for that device that they just developed, or they can leave the practice of medicine and own a company that distributes that device. But they can't do both because the profit motive associated with referring your own patients for something that you get a financial return on, a profit, is just not accepted. And that's, I think, one of the examples of why this industry and these regulations in this industry are outdated and really need to be changed. Yet another area of government regulation is ensuring compliance with charitable mission for those healthcare entities that are not-for-profit, and a very large portion of hospitals are still not-for-profit. They must be operated exclusively for charitable purposes, and these particular requirements will affect many arrangements, particularly arrangements between the hospitals and physicians, where hospitals try jointly with physicians to develop new imaging centers, new surgery centers that are more convenient for patients outside hospitals and hospital registration processes for outpatient services, for example. Lastly, the government steps in to ensure free competition in healthcare through Department of Justice reviews of mergers, high-tech joint ventures, agreements on fees and charges, joint purchasing arrangements, which are where hospitals get together and do volume purchases in order to bring the cost down, and multi-provider networks. All right, this is my list, but I think it was fairly consistent with a number of the things that our reporters had identified as some of the issues that are facing the healthcare industry that are likely to have a dramatic impact on how this industry evolves over time. Increasing healthcare costs, increasing number of uninsured. PPACA may help that, but we don't know for sure. The growing elderly population in the United States, the baby boomers are getting to their senior years. Unhealthy lifestyles, which is becoming more and more a topic in the media. Health information technology advances, also reported on. The crisis in emergency medicine services. Moving care from inpatient to outpatient settings. Growing workforce shortages among providers. Strong desire in this country for freedom of choice, not being locked into a particular provider in your network, but being able to go wherever you think you're going to get the best care, and access to health information or consumerism. Increasing healthcare costs, well, I think we've covered most of these. The result of an aging population that needs more services, better treatments, prolonging life, technological improvements, which are costly. Malpractice suits, where physicians start practicing defensive medicine because of the fear of malpractice claims. Intensive industry and labor costs are increasing, and there are significant and increased pharmaceutical costs. Increasing number of uninsured, Employers just can't keep purchasing, small employers in particular, health insurance for their employees. They can't afford to do it. The uninsured are not getting the care they need, and so they end up in hospitals with much more serious conditions when they show up. And hospitals are even converting to for-profit status in order to avoid the uncompensated care obligations that being a not-for-profit compels them to provide. The growing elderly population, gerontology services and nursing home services, great industries to be considering for the future. They will be growing by leaps and bounds. Again, the baby boomers have driven industries throughout the years, and from fitness and sports to vacation time to and gerontology services, nursing home services, what they call assisted living facilities are going to be growing very, very significantly in the next decade or so. Unhealthy lifestyles is another major issue driving our healthcare industry and the costs in the healthcare industry. These are resulting in employer incentives to employees through programs like smoking cessation, like weight loss reduction. And interestingly, I think one of the issues that we're going to have to deal with in the future is whether an employer can increase health insurance costs for unhealthy behaviors. Just like the life insurance companies charge you much higher premiums if you fly an airplane, ride a motorcycle, skydive, engage in what they consider risky behaviors, they charge you much higher premiums. Should employers, through the health exchanges, be requiring higher premiums if you engage in unhealthy lifestyle behaviors, if you smoke, if you drink to excess, if you're overweight? And I think that's an issue that we're going to have to address as our costs keep increasing and our expectations for medical care also keep increasing. Health information technology, great potential for reducing costs. But again, initially there is this huge upfront expense associated with putting that in place for hospitals, for physicians. And one of the issues we're experiencing in the industry right now is that the systems don't speak to each other. So while 3 hospitals in this community have electronic medical records, they cannot exchange things between them. And physicians, often who practice at more than one hospital, have to choose which software they're going to be on, which hospital software. And so they can communicate electronically with one hospital, but not with all. Now, interestingly, that exception in the Stark statute for electronic medical records and hospital funding of physician practices requires that the software be what they call interoperable. In other words, you can speak to any system, any hospital that has electronic communication. But it doesn't always work that way. And I can tell you right now that St. Luke's and Lehigh Valley Hospital have come right out to say, we can't make our systems interoperable, and they probably don't really want to either. But that's a big issue for whether or not we'll see these savings, because people don't always go to one provider or one hospital. They do, as we've said before, have wonderful ability to improve quality of care, increase efficiency in the transfer of care, wonderful efficiency, and also to provide specialized medical care, particularly in rural areas where they could not support a specialist in a particular area through the use of telemedicine services. Crisis and emergency medicine, I think probably I've covered this. But one of the significant issues here is that for the uninsured, this is really the only provider available to them. Doctors' offices will not accept a patient who doesn't come with an insurance card in hand, for the most part. And so all they can do is show up in the emergency rooms and clog the emergency rooms, rendering care to patients with actual emergency conditions less timely, because they have nowhere else to go. And it's a real crisis, and it's one that can only be addressed through things like PPACA and providing health insurance coverage where they get preventive care, where they get treated when they need to be treated and not when they have a medical crisis. Another major issue is the movement of care from the inpatient to the outpatient setting. Technological improvements are helping fuel that movement, laser, laparoscopic surgery as opposed to major invasive procedures. There's declining reimbursement for providing care in a hospital setting. But this, unfortunately, is putting an increasing burden on family members, resulting in a lot of lost work time because their family members coming home and needing a lot of assistance and care that used to be provided in a 4-day hospital stay. And over time, this is resulting in the downsizing and closure of hospitals. Growing workforce shortages will have a major impact on the healthcare industry. There's inadequate pay, even for physicians. There's stressful, demanding jobs that require 24/7 on-call coverage, very difficult lifestyle, particularly for a new or a young physician who tends to get more of that on-call responsibility. And there are many, many more opportunities now working for insurance companies from 9 to 5 with no on-call responsibilities. And this has been leading to a need on the part of US providers to recruit from other countries, nurses, physical therapists, doctors, and others. Many physicians I know are discouraging their children from going into the profession because it is so difficult. They spend so much time on paperwork and processing claims. The hours are awful. The pay continues to decline. It's not the career or the profession it used to be. And so many of them are discouraging their children from entering it. There are still lots of people going into the field and who still think of it as a calling. But it is not the same cushy lifestyle that it used to be, or used to be seen as. Another key issue for healthcare in the future is going to be the strong desire we have for freedom of choice in selecting our healthcare providers. It's a continued priority for patients, and it works against the insurers who want to limit the network of people that you can see within the plan in order to control how care gets delivered by those physicians. This is one way the insurers seek to limit costs, is to bring those providers into a small group and limit what they can do. And then lastly, access to that health information we've talked about and consumerism. I am sorry that we didn't have enough time here, but I am happy to stay for questions if anyone would like to ask any questions.
I'll have the last word, and then maybe stay
Didn't-
around. I know some of you have other classes and so forth.
I want to thank you on behalf of the class. I know it means a lot to me and everyone else here that presenters like you come and speak to us. And,
Thank
give
you
back
very
to the
much.
token of
Oh,
appreciation.
this is wonderful. Thank you. Thank you.